Dr. Vusumuzi Sibanda. I'm an orthopedic registrar at the East Kent Hospital University NHS Trust. And we did a paper called titled How Effective Are Telephone and Video Consultations in Shoulder and Elbow Clinics, using an analysis, analyzing using an objective scoring tool. So as a background, this study was conducted at the William Harvey Hospital, which is a district general hospital in the southeast of England. It is the biggest trauma center in the trust, and it has various orthopedic subspecialties, including shoulder and elbow, hand, spine, hips and knees, and foot and ankle. So by the time when we did this presentation, this project, the UK was in a third wave of the COVID-19 pandemic. As you might be aware, the first peak of COVID-19 cases started around March last year, and the second peak started later on in the second half of the year, around September 2020, ending around March 2021. Then the third peak started around June 2021. So because of this burden of COVID-19 cases, there was need to adapt clinical services to keep up with changing times and to protect patients as well as health workers. So some of the changes that happened in our department or in our hospital were that we saw an increase in virtual consultations. We saw that face-to-face consultations were at some point literally stopped, and everything was being done as either video consultations or telephone consultations. Elective surgeries were suspended as well. Handover, trauma meetings, and virtually most of the meetings were being done virtually. The graph on the right of your screen shows just how drastic outpatient clinics changed in a period of a few weeks, where at the beginning of March 2020, most of the consultations were being done as face-to-face. But by the end, towards the end of April, almost all of them were being done as telephone consultations. So the question that we were asking ourselves when we wrote this paper, where we noted that there was a drastic increase in virtual consultations. So our question was, how effective are these virtual consultations compared to the traditional face-to-face? And if there was any difference, how were we able to measure or compare the efficacy of the different consultation methods? So we went through literature, we did a literature research, and we came across this paper that was published on the 31st of October 2020, which sought to objectively assess the efficacy of telephone or telemedicine compared to face-to-face. So this paper came up with what is called the Ashford Clinic Letter Score, and this score objectively assesses the quality of consultation based on whether a clear working diagnosis was formulated, whether all relevant investigations were requested for or available at the time of the consultation, whether a clear management plan was formulated at the time of the consultation, and whether the consultation was deemed valuable by both the clinician and the patient. So each of these 4 parameters is a maximum score of 2. So if you use this parameter, the total possible score that you can get for any consultation was 8. So this is what the score looks like. So it looks at 4 parameters: A, whether the diagnosis was made and is scored accordingly, whether the consultation was recognized, whether a treatment plan was formulated, or whether consultation was deemed valuable by both the clinician and the patient. So as a way of background as well, our outpatient clinics are run by consultants, middle-grade doctors who are the registrars, and by dedicated specialty physiotherapists. After each consultation, the clinician who has seen the patient is required to then document a clinic letter to summarize the consultation. The clinic letters are then sent to the patient's general practitioner, to the patient themselves, and to other clinicians as required. So we then analyze these letters as a proxy to judge the quality of the consultation. So we looked at lectures that were detected or documented between March and April 2021 in an elective upper lip clinic. And we managed to find 30 face-to-face clinic lectures, 30 telephone clinic lectures, and 24 video clinic lectures. Then we engaged 2 independent assessors to score these lectures using the Ashford Clinical Lecture Score guidance. The scores were compiled and entered into Microsoft Excel sheets before being analyzed. So these were our findings. We found that from the face-to-face letters, of the 30 letters, 6 were new referrals, 4 were 24, 6 were new referrals, 24 were follow-up. Then for the telephone, 11 were new referrals, 19 were follow-up. For the videos, were 24 video letters, 13 were new referrals, and 11 were follow-up patients. So the average scores for face-to-face was highest at 7.967, followed by video consultations, which were 7.667, and telephone consultations, which were 7.333. And what we found was that when it came to new referrals or patients that were being seen in clinic for the first time, face-to-face consultations performed the best, followed by video consultations, and with telephone consultations performing the least. And with regards to follow-up patients, telephone and video consultations, the performance was similar. However, it was still inferior compared to face-to-face. And this is depicted in this graph at the bottom. And when it came to formulating treatment plan for patients, video consultations performed as nearly as well as face-to-face. All 3 modes of consultations, however, added value to the progress of the patients in specialist care. So points that we noted from this study are video consultations were as equally effective as face-to-face for new and follow-up patients. Telephone consultations were equally as good for follow-up patients. And all 3 methods were valuable in providing effective outpatient services as deemed by how valuable they were being found by both the clinician and the patient. So in conclusion, from our study, the conclusion that we came up with were that face-to-face consultations remain the gold standard in delivering consultations in outpatient clinics. Careful stratification of patients into video, telephone, and face-to-face will help with optimal delivery of care. So by this, we mean that patients who, for new patients who are coming in for the first time, it's important to stratify them and either assign them a face-to-face consultation or a video consultation. However, for follow-up patients, any of the 3 methods can be used, and it seems to be just as equally effective. More resources, however, are needed for virtual telemedicine. And some discussion points that I was hoping that we could discuss after this presentation are: how cost-effective are virtual consultations in our settings? How applicable are these findings or virtual consultations, that is video and telephone consultations, in poor resource settings? Is there a risk of us missing complications such as infections, joint stiffness, some things that we could have picked up had a patient come into clinic for a face-to-face consultations? And to what extent do virtual consultations reduce the number of patients who are lost to follow-up? I know in the first world, it might be not as applicable, but in the poor resource settings, some patients are lost to follow-up because they cannot travel long distances to come to the healthcare facility for a face-to-face consultations. So how effective or to what extent will a telephone consultation reduce the number of patients lost to follow-up? Then the other question that we'll want us to discuss, if possible, is can the same results be applied to other orthopedic subspecialties, seeing that this study was conducted only in the shoulder and elbow clinic? Can this also be applied to other surgical specialties such as ENT, such as general surgery? And can this also be applied to other fields of medicine in general? I thank you.